I'm Jessica Holsey-Nickel, and I'm the founder of the Addiction Policy Forum. We have 21 million Americans right now who are suffering with a substance use disorder. This is a personal issue for me. Both of my parents had a heroin use disorder, which meant prison for my mom, where we went to go live with my grandparents for a bit. It meant homelessness often, and child welfare and the foster care system.
There's a lot of stigma still that prevents people from getting the best care, both at a policy level and even at the healthcare interface. I think that we really need to work hard to change hearts and minds around this because people are dying every day.
I hope that in response to the horrific amount of destruction that we see from the opioids all around the country and other drugs of abuse, that we see people coming together to make sure that we provide the treatment that will allow people to turn their lives around.
Substance use disorders are progressive disorders, meaning that the longer that they go on, the worse they get. And as a substance use disorder gets more and more severe, the risk for mortality also goes up. So this is similar to something like cancer, where when you catch it at stage 1, your chances of recovery are very good.
One of our biggest gaps nationwide is to give our healthcare professionals the real tools they need, and the earlier we can intervene, the better the outcomes.
Aspart is the program that we're utilizing here at the University of Maryland, and it stands for Screening, Brief Intervention, and Referral to Treatment. This is a concept that's been utilized in other disease processes, but really addiction is its primary usage. What we do here is our nurses, when they're doing the triage process, they're screening the patient, so they use a simple tool to screen, and you're casting a wide net. So you want to try and make sure that you're capturing everybody that you have the potential to impact.
We don't wait for cancer patients to hit stage 4 before we decide to treat them. We don't wait for someone with diabetes to be in a coma before we decide to treat their illness, and it is the same for addiction.
If somebody screens positive, then we move on to the next step where we do that brief intervention and find out what the patient is receptive towards receiving, and if they can benefit from treatment, then we try and provide that referral to treatment.
The earlier you identify someone with a problem and engage them in treatment, the lower their mortality rates and the better the chance they have of gaining a long-term recovery.
This is why intervening in the emergency department is so important. This is an opportunity that we have to intervene with a patient that's at high risk. So a patient that comes in with a non-fatal overdose, we know that research has shown that they have the highest likelihood of having a future fatal overdose. So if we can intervene at that critical time, then we have the possibility to save a life. So not pushing it off to some other provider and taking ownership in the emergency department is really important.
I think the major reason that addiction is not treated like other diseases that we see in the emergency department is the stigma that's been associated with it, the component where we tend to blame the patient as if it were part of their control.
Nobody chooses addiction. This isn't a choice for us. We're not here because we're bad people. We're here because we have an illness.
Substance use disorders are medical illnesses. And like other medical illnesses, like diabetes or cardiovascular disease, they also involve behavior. So there are changes in the brain circuits that make it more and more difficult to stop using substances. Substance use disorders affect a number of circuits throughout the brain. One of the main ones is the reward circuit. And this is the circuit that is supposed to reinforce natural behaviors. So things like food, sex, caring for our children. And those type of natural rewards activate the circuit with a small spike in dopamine. But drugs activate the circuit much more powerfully. And what this means is that your brain ultimately learns incorrectly, but really powerfully, that these drugs are essential for your survival.
Over time, what this results in is a narrowing of behavioral repertoire. So people no longer have the ability to make as many choices in their environment, but they find their lives more focused on drug acquisition and drug using behaviors. This is due to changes particularly in the frontal lobes and how they feed back to the reward structures in other parts of the brain.
It's so hard to stop using substances because of the changes that occur in your brain when you have an addiction. So, imagine that you are struggling with an opioid use disorder and you try to stop. So the first thing that's going to happen is you're going to start experiencing withdrawal symptoms, and that, muscle aches, sweating, vomiting, diarrhea, some of the worst pain you've ever felt, insomnia, depression. And at the same time, the circuits that would normally help you control your stress response, they're not functioning. You know that the only thing that's going to make you feel better in that moment is to find a pill, to find some heroin.
So you get in this vicious cycle of using drugs to combat the stress of everyday life, or the stress of withdrawal, or the stress of coming down off of drugs.
You know that surrounding you is judgment and stigma. So how easy would it be in that moment, in all of those moments? Because you remember, this isn't just a one-time decision. This is an ongoing battle to not follow those impulses, to not succumb to those cravings. And so the combination of all those changes in your brain and the environment that you're in when you're trying to recover can make it incredibly difficult for someone to recover.
How do we really make people understand that this is a disease and illness not different from any other, and the entire family deserves and needs support when you're in crisis and when you need help? And I think it's the blaming and sometimes the stigma that we perpetuate that hurts not just that family, but it also makes recovery really difficult, because we need to have a welcoming community that can wrap around all of the family, but particularly our patients in their time of need.
Well, when someone has been revived using an opioid overdose reversal medication, they come out of it very scared, angry, and confused. And it's a very sudden feeling. It's all of a sudden they wake up and, who is this around me? How did I get here? You ruined my high. And they come out of this, it's scary. And it's a devastating feeling.
I've had family members that have had an overdose reversed, and then they're sort of just out of their, you treat them and street them and you move them along, or you don't have the healthcare infrastructure or the bed to help them, so you don't use that as an intervening moment. If we do a better job of creating the protocols in hospital settings for those that have already had a non-fatal overdose, I think we can have the biggest and the quickest impact to make sure that we get them the care that they need and prevent folks from having another overdose.
And the most important thing for us to know in the emergency department is that we can help, and that we can oftentimes be a first step towards getting them effective treatment and appropriate treatment. Sometimes just being a shoulder or lending an ear to listen to can be enough to help any patient take that first step.
One of the most important things for emergency department doctors to understand is that their concern matters. It might not always feel like it, and when they are engaged in a first conversation with a patient, they may be hesitant to engage in treatment, because as I said, they start to believe that this substance, the alcohol or the drugs, is essential for their survival. And so, thinking about engaging in treatment and having that substance go away can be an incredibly scary thought for them.
When I think back to what it felt like to be struggling with an opioid use disorder, it was terrible. It was a hard existence. It was a very lonely life.
Relating to patients can be one of the hardest things that you do in medicine, whether it's emergency medicine or any field. But the one thing that you have to do is you just have to slow down a little bit, take a little bit of time, and treat every patient like an individual and listen to them.
This is one of the main myths that most people across the public think about addiction. There's this concept that someone isn't going to be ready to engage in treatment until they hit rock bottom. And I think it's an important piece of someone's story when they're in recovery. People will often talk about that moment that turned them around. But from a clinical perspective, I think it's very important for people to understand that there is no real rock bottom. And you can't wait for someone to hit the bottom before engaging them in treatment, because they may not survive the fall.
I know that patients who are struggling with substance use disorders can be difficult patients. I was an incredibly difficult patient. I was that patient who kind of roll your eyes when they were coming in, who is a pain in the neck.
When I'm talking to a patient that is coming in with an overdose or just has a substance use disorder, when I talk to them, I'm listening more than I'm talking. And I ask a lot of open-ended questions, and I just kind of want to figure out what got them a little bit to where they are today, and probe a little bit when it's appropriate, and find out whether they're interested in getting into treatment. Just really learn more about them. It takes a little bit extra time, but just by listening a little bit more, asking them, how can I help you through this? What can I do to help you get through this problem that you have? Most of them realize that they have a problem, and most of them don't want to be in this cycle of addiction, and they would love to have a way out. So they're usually pretty receptive to somebody asking a question like that, and listening.
Getting off heroin is the hardest thing I've ever done. And so we don't want to create more barriers for people. We want to break down those barriers and bring people into treatment.
And acknowledge that it's not an easy road, and there's no simple answers, and everybody is going to need something a little bit different than the next person. But acknowledge how difficult it can be.
One of the other things that we've sort of encountered is reticence, or the questions about how many times do we reverse an overdose? How many chances does a person get for their life? We don't make those same qualifiers when it comes to how many tourniquets are we going to use after a gunshot wound or after an injury. Sort of how many EpiPens are we going to use on this person with an allergy? These are our patients, they're our family members, our daughters, our sons, our moms, our dads, and there's no sort of number of lives you get. This isn't a video game, this is real life, and we need to make sure that the medicines are available to bring folks back to life and then connect them with treatment.
Talk to them about take-home naloxone and try and educate them on how to use it, the indications for using it, and get that medicine in their hand so that they can leave the emergency department with that if possible. A lot of this takes some work ahead of time, but once you get those processes in place, then you can have a lot of impact with patients.
It's important for the provider to be a source of education so that they can share with the patient what their options are and try to find the one that is the best fit. I think sometimes patients also get pressure from their family about what type of treatment is or isn't acceptable. And I think we need to empower patients to really understand what their options are and to choose the best one for themselves.
And if they want help, it needs to be available right then and there. So that's the window of opportunity that we can't miss, we can't mess up. And so, the emergency department nurses, the doctors, are all a critical piece of that team, but that recovery coach would make a world of difference to be part of that team.
Peer support counselor is someone who can connect with that individual and say, I've been there. And that's a type of relationship that draws the patient in and enables them to feel supported and enveloped with not only information but love.
Help them find a place to stay, or they can help them connect with people in mutual aid programs. They can be their recovery coach to say, what do you need? How can I help you? What's your game plan? Let's work on this together.
They can go in and start that discussion, and they have that street cred where the patients that are having active addiction, they can relate to them a little bit better.
So this is making all the difference in the world, is not only getting them engaged in treatment, helping them to get to that first appointment, finding the resources that they need, is by having a recovery coach, somebody who's been there, and help them through those challenges.
It's essential that we use the scientific process to guide how we implement treatments. That's what we mean by evidence-based care or evidence-based treatment. We mean that there have been well-done studies to prove that an intervention has the effect we're looking for.
The best model that we think of right now for treating addiction is what we call a chronic care model.
We're very fortunate because we have medications that are effective and that have been FDA approved. The medications that we have that are available for opioid use disorder include methadone, naltrexone, and buprenorphine. The evidence actually shows us that when you compare tapering or detoxification against maintenance on a medication, that detoxification is actually a risk for death. That once someone is detoxified, they're at very high risk for relapse. Their tolerance has been reset so that the drug that they took once before without any difficulty can now kill them. So it's really not uncommon for people leaving circumstances like jail or a detoxification program to come out and then have a fatal overdose within their first week of release.
Medication-assisted treatment is life-saving, and it is in no way substituting one addiction for another. You see people who have a substance use disorder actually go into remission on medication, which means that you have no signs or symptoms of the disease. Just like you would with cancer, you want your patients with cancer to go into remission too and have no signs or symptoms.
We can administer buprenorphine in the emergency department, and then with having set up this relationship with treatment programs, we can give them the first dose in the emergency department, and then either that same day or next day they get into that long-term treatment program. The research that has been done so far is showing that patients are staying in treatment longer. It's much more effective if you get them started as soon as possible in the emergency department when they're most receptive to treatment.
The medication's actually the foundation of treatment upon which other treatments can be added. The medication treats the withdrawal, the medication decreases the craving, the medication stabilizes the level of physical dependence. The medication prevents someone from having a fatal overdose.
MAT stabilizes them to give them the opportunity to do group therapy or individual therapy or both, and also get that support from family and friends who are there for them, so that they have a network providing them with encouragement and the ability to call if there's a chance that they're reaching a trigger. And basically, after they've been stabilized on MAT, they do really well in group or individual counseling.
We have 23 million Americans that are in recovery, and we need to make sure that everyone, families included, have resources and support.
The recovery process involves, or can involve, really rebuilding their entire lives. So, finding those meaningful pursuits that, that they have passion for, rebuilding friendships, repairing relationships with their loved ones, engaging in job training, and finding a support system that doesn't use substances.
Recovery looks different for everyone. Recovery on the inside is about growing, healing, and becoming healthy and happy in our lives. It's about having that spark back in our life, about celebrating and being grateful for life after, because we've come so far, we've come through the tough times.
I'm hopeful because we've had a tendency to marginalize not just those that have an addiction, but their whole family. So as we unite as a community to bring all families and patients together to really do this work in a new way that follows the science, that builds a comprehensive response, that values individuals that are struggling with this illness, that tackles stigma, but also is working to integrate this into healthcare so we have better outcomes for our patients.